I'd like to go through a few cases of sciatica and suspected low back nerve root disorders. For each case, we'll go through the patient's symptoms and identify any red flags or warning signs that would indicate a severe disease. We'll go through the possible diagnoses and come up with the most likely diagnosis in each case. We'll also go through a management strategy, including any additional testing that's needed and the treatment that may be provided. And all these cases are similar to those that we deal with in our clinic on a regular basis. In our first case, we have a 39-year-old woman who presents with a 1-year history of radiating lower extremity pain that occurs when she walks, is relieved by sitting or bending forwards, and worsened if she bends backwards. She traces the L5 dermatomes as her pain location, stating that she feels pain mostly on the left side, only sometimes on the right side. On physical exam, there's grade 4 out of 5 strength of the extensor hallucis longus. The straight leg raise is negative on both sides over 90 degrees. Valsalva's test is negative, and the lower pulses are normal. There's a lack of hypomobility of L4 on P to A or motion palpation spring testing, and the Baton score is 7 out of 9. The first thing to look at in this case is when the lower extremity pain occurs, is when she's walking. And this is a pattern called claudication. There's 2 types of claudication. There's neurogenic claudication of the nerves and vascular claudication. Our patient here has neurogenic claudication. The reason why you know this is because there's a directional preference. It's relieved by sitting or bending forwards. And the reason why is when you do those activities, it actually opens up the lumbar spinal canal. On the opposite side of that, when she bends backwards, it closes the lumbar spinal canal and makes her pain worse. She's telling you that the pain is on the outside of the thigh, the anterolateral leg, and the dorsum, or the top of the foot, and we interpret that as the L5 dermatomes approximately. She's feeling pain actually on both sides. This is very, very important, and this is giving a clue here that more than one nerve root, or this is polyradicular. So there's an involvement of at least one nerve root here. On physical exam, we have the weakness of this muscle here, extensor hallucis longus, which controls bringing the big toe basically up towards the face, and it's innervated by L5S1. The straight leg raise is negative, and that's a big clue here because in cases of spinal stenosis, such as seen in claudication, you will often have a negative straight leg raise because you're actually flexing the spine, and again, that's that directional preference that we see. Whereas in a disc herniation, a lumbar disc, you'll have a positive straight leg raise oftentimes, as well as a positive Valsalva's test where you're bearing down with your mouth closed, and that'll aggravate the lower extremity pain. So the pulses are normal, which is very nice because it helps to rule out the vascular claudication. And the Baton score, that is something that you can look at for ligament laxity, which if you're suspecting degenerative spondylolisthesis, that can help predict instability of the segment. So it's a clue that the ligaments are not tight and basically things can slip. So there's 2 main things that we're looking at here. Degenerative spondylolisthesis, which is a cause of spinal stenosis, claudication, and that is really the most likely diagnosis in this case. The other thing we want to consider, though, is a lumbar disc herniation at L4 and L5. One of the key ways to distinguish between these is going back to this polyradicular, more than one nerve root involved. Because when you have a degenerative spondylolisthesis, oftentimes you can have damage to more than one nerve root here. So this is L4, the L4 nerve root coming down. There's one on the left and there's one on the right side. And then this L5, same thing. There's one on each side. And when you have vertebra slipping down, you can actually stretch the one below and you can pinch on the one at the same level. In her case, she's actually stretching both of the ones down below, the L5. She's stretching both of those, one more so than the other. But this is a key point in the sense that spinal stenosis or degenerative spondylolisthesis, which is a cause of spinal stenosis, oftentimes affects at least two nerves or nerve roots, whereas a lumbar disc herniation is unilateral or only on one side of the body in 90% of cases. And that's what this chart is all about here. So an L4-5 lumbar disc herniation, you can see the percentages here. It affects the L5 nerve root 94% of the time, and again, it's usually unilateral. Whereas a degenerative spondylolisthesis, at that same level, it can affect L5 nerve root on one side, both sides, or even the L4. And that's not what we're seeing in this case, but it goes to show you that with a degenerative spondylolisthesis, you really need to be thinking about when you're seeing more than one nerve root distribution, and that's right, left, or at two different levels even. So this is pretty clear. We have the directional preference towards flexion, the claudication, the absence of the straight leg raise, and the Valsalva's test, and also demographics, being female, and that age is very typical to see at this level. So as far as treatment goes, we went ahead and got the x-ray for you. So that helps to solidify the diagnosis in this case. You can see the anterior vertebral body line coming down to show that the alignment is off, and that's very characteristic here because this is not lining up, and you can tell that there's a slippage here of this. There's also a loss of disc space, and that's all part of the pathophysiology and how this develops. So the disc starts to wear down, and you can compare it at the levels above. That puts more stress on the facet joints or the zygapophyseal joints. You can see that they are white, and that's indicating a sclerosis or a degeneration at those levels. Basically, all the ligaments, the bone structures that hold all this together is starting to wear down, and that's allowing this vertebra to slip forward. That's stretching the fifth lumbar nerve root and creating the picture that we're seeing here clinically. On physical exam, sometimes you can pick up some of these things. You can see sometimes what's called a step defect. You can feel these spinous processes, and this one is a little further in. You can also sometimes see a fold in the skin or a crease, basically, where this is pulling the soft tissue forward. And what you can do next is you can actually do a loaded view. You can put a backpack on the person with weights in it, and that will actually slide this even further. And what you're looking for there is called instability. If it slips more than 3 millimeters, you can do a flexion extension view to do the same thing to see if it slips more. But regardless of that, what you should be looking at here as far as treatment is really just exercises to stabilize the low back. And you can also work in flexion, like bicycle type exercises, just to do exercise without making this worse. You can also work the core muscles, such as the multifidus. What I like to do in cases like this is abdominal curl up, which is very nice, very entry level type exercise for the core, and that's going to help bring this back. So you can also see on this x-ray that there is a hyperlordosis. If you drop a straight line down from L3, it's supposed to connect right here with the anterior sacral base, and it's way too far forward. So we want to bring this whole curve here, I want to bring this more like that and connect it more with the sacrum. So the multifidus exercise, like side bridge on the knees, can help strengthen this multifidus muscle, which will help anchor that vertebra back in place. Some people will use a brace. That's a good idea in some cases. It's not harmful at all. They've done some research that shows that it doesn't really weaken you. As long as you're doing the exercises, you're good. So that might help. And nutrition is something I like to look at as well. And you can help do strengthening protocols for the bones and the ligaments. What I like to do is vitamin D3, K2, and minerals for all of the connective tissue in this area to hold everything together and support it. And In our next case, we have a 45-year-old woman who reports a 1-month history of an intermittent burning, radiating pain from the lateral right hip along the lateral thigh to slightly beyond the knee, which is worsened with exercise and with lying on the right side while trying to sleep. This problem began after she started a new exercise class. On physical exam, there's point tenderness at the right greater trochanter. There's no sensory deficit. The medial hamstring reflex is graded 1 on both sides. The Achilles and patellar reflexes are 2. There's grade 4 out of 5 strength of the right thigh abduction, which also causes local lateral hip pain on the right side. And the other lower extremity muscles are normal strength. There's a lack of iliotibial band length using the modified Thomas test. Straight leg raise, femoral nerve stretch test, and Valsalva's test are all negative. The pain pattern in this case, going down the thigh and stopping just beyond the knee, doesn't really help you very much because there's actually 3 conditions that have this similar pain pattern. One of them is greater trochanteric pain syndrome. L4 and L5 radiculopathy can look like this, as well as neuralgia paresthetica. So looking back at the symptoms, her pain's coming on with exercise and with lying on the right side while trying to sleep. This is a very, very classic symptom because when you're lying on the side, you're actually putting pressure right on that hip. And that leans more towards greater trochanteric pain syndrome. It's a very classic symptom because there's bursa in here, the subtrochanteric bursa that can get irritated, the subgluteus maximus bursa, also the myofascial connections here of the gluteal and hip muscles that can get irritated when you sleep on it if there's any sort of tendinosis, bursitis, inflammation, or irritation going on in that area. Same thing when you feel at the right greater trochanter, that's very painful. That's very typical of a greater trochanteric pain syndrome appearance. The fact that there is no sensory deficit helps to rule out any sort of radiculopathy. And the reflexes don't really help us in this case, but because the medial hamstring reflex being grade 1, you might think it's low, but really it's on both sides, so it doesn't matter. There's 4 out of 5 strength of right thigh abduction. That doesn't help us very much, but what does help us is that when you test that muscle, it's causing local pain right here on the outside of the hip. That's very, very important because it's telling you that these muscles are irritated. So the hip abduction muscles are the tensor fasciolata, which is right here, the gluteus medius, gluteus maximus, gluteus minimus, which is right below this, the piriformis, the obturator internus. And when you're using all those muscles, it irritates the patient's pain. And she just started a new exercise class, so there's a chance that the biomechanics are not right, or she's doing some sort of overuse injury here, where she's irritating it, or she's just not used to whatever she's doing. And I've seen this in a bowler. When he followed through on his swing, he would thrust through the hip in an extended position, and it would irritate his hip, and it led to that burning pain down the thigh. So it's very typical. I've also seen the sleeping on the side is very, very classic. I've seen that in my patients to irritate this. So it's pretty characteristic of a greater trochanteric pain syndrome. The radiculopathy is less likely in this case because we don't have any of the nerve tension tests, directional preferences. Neuralgia paresthetica is also less likely because that's usually related to some sort of compression around the inguinal ligament, like a tight belt. And this is a very, very confusing condition at times. It's actually been found that in a recent study they noticed that in 247 patients referred to a spinal surgery center for low back pain, 20% of them had greater trochanteric pain syndrome. About 50% of them already had an MRI of the lumbar spine, and one of them actually underwent surgery for the low back. So it's very confusing. And there's an overlap here with the iliotibial band syndrome, and that's all included basically in this diagnosis. because it's a very all-encompassing diagnosis. It's not just bursitis, it's not just tendinosis of those muscles. All those things are lumped into this greater trochanteric pain syndrome. So you can include the iliotibial band. And that's actually what's probably generating the pain in this patient, because there are pain fibers in here that will go into the central nervous system, and that's probably why the patient's feeling all this burning pain down the thigh, is this big tendon here, the IT band. So as far as treatment goes, what you want to start off with is just conservative care. There's a few ways to go about that. One of the ways is the anesthetic injection right into not the hip joint, but the structures that we talked about earlier, the myofascial structures and the bursa. That can be very, very helpful in speeding up recovery from this. If you get greater than 50% relief, it's basically considered a diagnostic, but it actually helps out the patient recover as well. There's a lot of different manual therapies here, and this is a good article about that, shockwave therapy. What I like to do is IASTM, or instrument-assisted soft tissue mobilization, which is basically a form of massage where you're rubbing through here with a metal object. There's also different types of stretches, modalities like laser, electric stimulation through there that can be very helpful. And so what you're looking at as far as a prognosis here is like 1 to sometimes even 4 months. And the anesthetic injection can sometimes speed things up, but the manual therapy is more of like a long-term solution. Great. In our next case, we have a 53-year-old woman who presents with a 3-month history of low back pain and right lateral leg burning pain. She sat with her legs crossed during the interview. She denies a history of trauma and weight loss. On physical exam, her body mass index is 19, so she's fairly thin. There's hypoesthesia to light touch over the painful area, shown in the image. There's grade 4 out of 5 strength of right ankle and toe dorsiflexion and ankle eversion, with the other low extremity muscles testing normal. The patellar, medial hamstring, and Achilles reflexes are normal on both sides. The percussion test is positive at the right fibular neck and reproduces the chief complaint. Straight leg raise variation 1 and variation 2 are negative, whereas straight leg raise variation 4 is positive on the right side for reproduction of the chief complaint in the leg. In this case, the pain pattern, again, can be very misleading because this area of pain is basically identical between L5 radiculopathy and a common peroneal nerve lesion. It can overlap, it can be exactly the same, and you don't want to rely on that to distinguish between those two diagnoses. So going through the history, she's thinner, she's more at risk for a peripheral nerve compression. That puts you more in the category of a common peroneal nerve lesion. The hypoesthesia of light touch, that just shows that there's actually a nerve deficit. I would like to use a cotton ball, that's what I normally do, to test the light touch here. The weakness of the ankle and toe dorsiflexion, that's, again, very confusing because there's an overlap here of the innervation of the muscles between the nerve root, L5 radiculopathy, and the common peroneal nerve. They innervate a lot of the same muscles. However, L5 radiculopathy innervates a little bit more, and you may find thigh abduction weakness in L5 radiculopathy, as well as ankle inversion weakness. And so absence of those two features puts you a little more in the common peroneal nerve category here. And also the medial hamstring reflex is for the L5 nerve root, and that's actually normal in this case, and you will see that be a grade 2 on some thinner patients, and that's very, very good in this case because it helps to rule out an L5 radiculopathy. You can see it has a pretty good negative predictive value to rule out a damage of that nerve root. And so the nerve root tension tests are also pretty helpful in this case. There's a lot of variations of the straight leg raise. So straight leg raise variation 1, you just lift the leg up to the ceiling like this. And in variation 2, you'll actually bring the toes up towards the face and the ankle up towards the face, dorsiflex it. That's variation 2. Those are more for the tibial nerve, and those being negative helps us rule out a radiculopathy. What we're seeing in this case is a straight leg raise 4, and you'll actually internally rotate the hip, and you'll also invert the ankle here, and that's variation 4, and that stretches or stresses here the common peroneal nerve. Another really important finding here on this physical exam is the Tinel's test, where you're tapping here and you're reproducing that burning pain down into the leg and the foot. That's very, very characteristic of a peripheral nerve lesion of the common peroneal nerve. So that is the most likely diagnosis. As far as treatment goes, you want to just have the patient try to avoid crossing the legs. If they're doing an activity where they cannot do that for whatever reason with work, then sometimes even you can have a knee pad, and that will help protect this from compression. And you really want to monitor the patient for up to 4 months and see if this improves. And along the way, you can do some conservative treatment, maybe some myofascial treatments, maybe some proximal tibiofibular joint mobilization or myofascial treatments, or electric stimulation or laser could all possibly be useful. And again, if it does not improve in that time frame, you can go forward with imaging, but really the electrodiagnostic studies will help you distinguish between those two conditions, the radiculopathy and the common peroneal nerve lesion. So those things are nerve conduction velocity tests and electromyography. Those can really help you distinguish if you're really not clear and if it may be more confusing than this case was and the patient's not improving. This study was a very, very good study, and it shows how the peroneal nerve lesions can be misdiagnosed as radiculopathy. They actually had a case where a patient underwent spinal surgery before finally having a doctor that realized all the symptoms were coming from this common peroneal nerve, and there was nothing wrong with the low back. Very unfortunate for the patient, but in the end they got it all figured out. In our next case, we have a 50-year-old man who presents with a 2-week history of a burning feeling of the left groin, anterior thigh, and knee, leg weakness, and in general he feels unwell. This has prevented him from his usual trail biking. He notes a painless rash on the left knee and denies having any injury or history of knee or heart problems. On physical exam, his vital signs are normal. Thigh adduction strength is grade 4 out of 5, and knee extension on the left is also 4 out of 5 strength, and there's hyporeflexia of the left quadriceps. There's a positive femoral nerve stretch test on the left side, which reproduces his chief complaint, and the left knee is non-tender, and there is no joint effusion. So what we're looking at here is pretty clear disorder of L3 or L4 nerve root. The question is, what is causing it? This is our first case that we're seeing red flags, and the patient just does not feel well, and he also has a rash on his knee, and that is very strange, especially when you're having neurological symptoms mixed in. And when you're having a radiculopathy with constitutional symptoms like just malaise or not feeling well or just being sick overall, you really need to be thinking about infections, tumor, or inflammatory conditions like polyarteritis nodosa, or even gout, which can affect the spine, sometimes the knee. But in this case, what we're seeing is that there's nothing really wrong with the knee because it's not tender and there's no swelling in it. And this is a rash that it might be a Lyme disease rash. It looks like it could be. There's not exactly a big central clearing, although there may be a little one here. So this isn't what's called the typical erythema migrans with the central clearing, but it's sort of characteristic of Lyme, especially when you look at the tick exposure risks of being in the woods, trail biking, and it also depends on your geography as well. But it definitely does not look like gout because there's no swelling in the joint and it's not tender. So you can pretty much rule out gout, and also polyarteritis nodosa. The rash looks totally different, and it's very, very rare, and it shouldn't look like this at all. So it's probably not polyarteritis or gout, although it could be lumbar disc herniation. The thing is this, you really want to start treating Lyme if you're suspecting Lyme. And there's also an overlap here, Lyme and lumbar disc herniation, where there's a connection between the two things. The pathophysiology overlaps between them. And the reason why is because Borrelia, the spirochete, the bacteria with Lyme disease, can actually get into the nervous system, spread throughout the body, and sometimes it even gets into the dorsal root ganglia right in here. And if you have any sort of disc problems underlying, it will basically compound upon it and make it even worse. So you'll get a severe nerve root problem down, a radiculopathy. And it may be that the disc problems predispose you to the infection in that area because there's a lack of blood flow, or it could just be that the Borrelia bacteria actually worsens this because of inflammation. But either way, the two things there are known to have an association, and this is a really nice article that summarizes all of that. So as far as treatment in this case, a lot of doctors would likely just go straight into the antibiotics and then make their way down into the testing, because you really want to be sure and clear what's going on in this case. There are supplemental or adjunctive therapies that you may have in our clinic. Sometimes with Lyme disease, we will do hyperbaric oxygen therapy. We will do sauna, infrared sauna, and we will do supplements such as zinc, just for the immune system, or even iodine. And herbal, sometimes like Samento, can be very good.